So welcome to Unit 12, Abnormal Behavior, and we are on Module 67, Depressive Disorders, Bipolar Disorder, Suicide, and Self-Injury. There are 3 learning targets. Contrast major depressive disorder, persistent depressive disorder, and bipolar disorder. Analyze how the biological and social cognitive perspectives help us to understand depressive disorders and bipolar disorder. And finally, explain what risk factors increase the risk of suicide and discuss what we know about non-suicidal self-injury. And just to let you know that these slides do align with Myers Psychology for the AP course 3rd edition textbook. So how prevalent is depression? So in the past year, have you at some time felt so depressed that it was difficult to function? If so, you're not alone. In one survey, 31% of American college students answered yes. In a survey of American high school students, 29% felt so sad or hopeless almost every day for 2 or more weeks in a row that they stopped doing some usual activities. Excuse me. What is major depressive disorder? So we hear the term depression a lot, but what is major depressive disorder? It is a state of hopelessness and lethargy lasting several weeks or months. How is it diagnosed? So at least 5 signs of depression, including either depressed mood or loss of interest or pleasure, lasting 2 or more weeks. Those must be present for a diagnosis of major depressive disorder. So the DSM-5, the Diagnostic and Statistical Manual, 5th edition, classifies major depressive disorder as the presence of at least 5 of the following symptoms over a 2-week period of time, minimally including depressed mood or reduced interest. So those symptoms are depressed mood most of the time, dramatically reduced interest or enjoyment in most activities most of the time, significant challenges regulating appetite and weight, significant challenges regulating sleep, physical agitation or lethargy, feeling listless or with much less energy, feeling worthless or feeling unwarranted guilt, problems in thinking, concentrating, or making decisions, or thinking repetitively of death and suicide. What is persistent depressive disorder? Persistent depressive disorder is also called dysthymia, is similar to major depressive disorder, but with milder depressive symptoms that last a much longer period of time. So how persistent is depressive disorder? How is persistent depressive disorder diagnosed? So adults diagnosed with persistent depressive disorder, also called dysthymia, have increased a mildly depressed mood more often than not for 2 years or more. So it's for a long period of time, but the symptoms are milder. So spread out over a long period of time, but milder symptoms. They also display at least 2 of the following symptoms: difficulty with decision-making and concentration, feeling hopeless, poor self-esteem, reduced energy levels, problems regulating sleep, and problems regulating appetite. So when asked, have you cried today? Americans have reported doing so more often in the winter. For some people, depressive symptoms may have somewhat of a seasonal pattern, returning each winter. Some people seem to notice a lot of mood changes depending on the season. What is bipolar disorder on the other hand? We've been talking about depressive disorder, but what is bipolar disorder? It's a disorder in which a person alternates between the hopelessness and lethargy of depression and the overexcited state of mania. This disorder used to be officially called manic depressive disorder. Because of the periods of mania, but is now called bipolar disorder. When a depressive episode ends, a euphoric, overly talkative, wildly energetic, and extremely optimistic state called mania follows. But before long, the mood either returns to normal or plunges again into depression. It's sort of these cycles. What does it feel like to suffer from bipolar disorder? This image is a pretty telling image of what it feels like to suffer from bipolar disorder. In her art, Life Has a Two-Headed Beast, bipolar artist Abigail Southworth illustrated her personal experience of bipolar disorder. What does research show us about the manic phase of bipolar disorder? During the manic phase, people with bipolar disorder typically have little need for sleep. They show fewer sexual inhibitions. Their positive emotions persist abnormally. Their speech is loud, flighty, and hard to interrupt. They find advice irritating. They need protection from their own poor judgment, which may lead to reckless spending or unsafe sex. Thinking fast feels good, but it also increases the risk-taking, which can be very problematic. So what is the relationship between bipolar disorder and creativity? So in milder forms, the mania phase, the manic parts, the mania's energy and flood of ideas can fuel creativity. Clusters of genes associated with high creativity increase the likelihood of having bipolar disorder, and risk factors for developing bipolar disorder predict greater creativity. What does research show about the implications of bipolar disorder? Though bipolar disorder is much less common than major depressive disorder, it is more dysfunctional, claiming twice as many lost workdays yearly. Bipolar disorder is a potent predictor of suicide as well. Americans are twice as likely as people of other countries who have ever had a diagnosis of bipolar disorder. What are biological explanations for major depressive disorder and bipolar disorder? So we're going to talk about some genetic predispositions, neurochemical imbalances, and nutritional deficits. So what is the genetic factor? The risk of being diagnosed with major depressive disorder or bipolar disorder increases if your parent or sibling has the disorder. If one identical twin, those monozygotic twins, is diagnosed with major depressive disorder, the chances are about 1 in 2 that at some time the other twin will be too. If one identical twin has bipolar disorder, the chances of a similar diagnosis for the co-twin are even higher, 7 in 10, even for twins raised apart. So what is the heritability of some of these disorders? So using aggregated data from studies of identical and fraternal twins, those monozygotic and dizygotic twins, researchers estimated the heritability of bipolar disorder, schizophrenia, anorexia nervosa, major depressive disorder, and generalized anxiety disorder. And you can see that bipolar disorder, and to a little bit less of an extent, schizophrenia do seem to have higher heritability rates, with generalized anxiety disorder having a little bit of a lower one. Which brain structures play a role in depression and bipolar disorder? In people with bipolar disorder, studies discovered a decrease in myelinated axons and enlarged fluid-filled ventricles. Depression can cause the brain's reward centers to become less active. During positive emotions, the left frontal lobe and an adjacent reward center become more active. How is the brain changing during a manic episode? So in a bipolar individual. So the top-facing PET scans show that the brain energy consumption rises and falls with the patient's emotional switches. Red areas are where the brain rapidly consumes glucose. How do neurotransmitter systems influence depressive disorders and bipolar disorder? So norepinephrine, which increases arousal and boosts mood, is scarce during depression, and it's overabundant during mania. So it's really interesting to think about in terms of bipolar and norepinephrine. Serotonin is scarce or inactive during depression. One study showed that depression is related to the combination of two factors: significant life stress plus a variation of a serotonin controlling gene. How does physical exercise reduce depression? Well, repetitive physical exercise like jogging or some other types of aerobic exercise can reduce depression in part because it increases your serotonin level, which affects mood and arousal. So when people are giving you that advice to get active and get moving, it can boost your mood. That's actually true. In one study, running for 2 hours increased brain activation in regions associated with euphoria. How about diet? So people who eat a heart-healthy diet, Mediterranean diet, heavy on vegetables, fish, and olive oil, getting a good amount of fat, have a comparatively low risk of developing heart disease, stroke, late life cognitive decline, and depression, all of which are associated with inflammation. So excessive alcohol use also correlates with depression, but that's partly because depression can increase alcohol use, but it's also mostly because alcohol misuse ends up leading to depression. How about life experiences? How did they play a role in depression and bipolar disorder? Diet, drugs, stress, and other environmental influences lay down epigenetic marks, molecular genetic tags that can turn certain genes on and off. Animal studies suggest that long-lasting epigenetic influences may play a role in depression. How does the social cognitive perspective explain depression and bipolar disorder? Well, the social cognitive perspective explores how people's assumptions and expectations influence what they perceive. Many depressed people view life through sort of not rose-colored glasses, but dark glasses, the dark glasses of a low self-esteem. Their intensely negative assumptions about themselves, their situation, and their future lead them to magnify bad experiences and minimize good ones. So how do our thoughts then lead to depression? Expecting the worst. Depressed people's self-defeating beliefs and their negative explanatory style feed their depression. Overthinking, which is termed rumination, can also have an effect on depression. So sitting there thinking over and over again, things like, I never know what to say to people. No one wants to be around me. Will I ever get a job? Do I smell bad? I'm so ugly. Ruminating over and over again about what these types of thoughts can actually lead to depression. So rumination, again, is compulsive fretting. It's overthinking our problems and their causes. Psychologist Susan Nolan Hoeksema, not sure if I'm saying her name correctly, related women's higher risk of depression to what she described as their tendency to ruminate or overthink. Relentless, self-focused rumination can distract us, increase negative emotion, and disrupt daily activities. So how does social media comparisons factor into depression? This is interesting to think about in the age that we live. When people scroll through social media feeds and see Maria's having a blast with friends, Angelique's enjoying a family vacation, and Tyra looks super in her bathing suit, the response your brain might think, my life is terrible, right? And that can lead to depressive thoughts. So explanatory style, who or what we blame for our failures, seems to be similar for those suffering from depression. So you can look at this visual on the right. So if you have a breakup with a romantic partner, if you have a stable style, I'll get over this. This is hard to take. If it's temporary, this is hard to take, but I will get through this. Global, without my partner, I can't seem to do anything right. Specific, I miss my partner, but thankfully I have family and friends. Internal, our breakup was all my fault. External, it takes two to make a relationship work and it wasn't meant to be. You can see that the stable, global, internal, all those that type of explanatory style can lead to depression, but those temporary, specific, external explanatory style combination can lead to more successful coping. So what explanatory style seems common in those diagnosed with depression? Individuals diagnosed with depression often explain bad events in terms that are stable, like it's gonna last forever, global, it will affect everything I do, and internal, it's all my fault. So stable, global, and internal. So what does research show about explanatory style of people diagnosed with depression? Depression-prone people respond to bad events in an especially self-focused, self-blaming way. When people diagnosed with depression describe themselves, their brains show extra activity in a region that processes self-relevant information. In addition, individuals prone to depression have self-esteem that is more plastic. It climbs with praise and it plummets with threats. Learned helplessness. We've talked about this several times if you've listened to other modules, going back to some of the actual learning modules, and we learned about Martin Seligman's research with dogs. So learned helplessness is the hopelessness and passive resignation an animal or person acquires when unable to avoid repeated aversive events. So uncontrollable bad events, perceived lack of control, which turns into generalized helpless behavior. How might learned helplessness lead to depression? Well, self-defeating beliefs may arise from learned helplessness. Pessimistic, overgeneralized, self-blaming attributions may create a depressing sense of hopelessness. Why is depression more common among Western cultures? Well, the psychologist I just mentioned, Martin Seligman, pointed to the rise of individualism and the decline of commitment, religion, family in Western individualistic cultures. In non-Western collectivist cultures where close-knit relationships and cooperation are the norm, major depressive disorder is less common and less tied to self-blame over personal failure. So how is depression a vicious cycle? Well, depression is both a cause and an effect of stressful experiences that disrupt our sense of who we are and why we are worthy human beings. Okay, so we have a stressful experience, leads to negative explanatory style, combined with a negative explanatory style, it leads to a depressed mood and cognitive and behavioral changes, and it goes around and around. So what are the pieces of the depression puzzle? Again, stressful experiences interpreted through a ruminating, pessimistic explanatory style turn into a hopeless, depressed state that hampers the way the person thinks and acts. This in turn fuels further stressful experiences. See, that's why I was saying it goes on and on and on. What does research show regarding suicide? Each year, over 800,000 despairing people worldwide will elect a permanent solution to what may have been a temporary problem. For those who have been anxious, the risk of suicide is tripled. And for those who have been depressed, the risk is quintupled. People seldom commit suicide, though, while in the depths of depression, when energy and initiative are lacking. The risk increases greatly when they begin to rebound and become capable of following through. So what about gender and the impact of and age on the impact of suicide? So women are much more likely than men to attempt suicide, but men are more likely to be successful in their attempts, 2 to 4 times more likely to actually end their lives. In late adulthood, suicide rate increases with the highest rate among 45 to 64-year-olds and the second highest rate among 85-year-olds and above. What are some factors that increase the risk of suicide? Men exposed to a family suicide were 8 times more likely to commit suicide than were non-exposed men. Gay, transgender, and gender non-conforming youth facing an unsupportive environment, including family or peer rejection, are also at increased risk of attempted suicide. Following highly publicized suicides and TV programs featuring suicide, known suicides increase. So what factors may trigger suicidal urges? Suicidal urges typically arise when people feel disconnected from others and a burden to them, or when they feel defeated and trapped by an inescapable situation. People, especially older adults, may choose death as an alternative to current or future suffering, a way to switch off unendurable pain and relieve a perceived burden on family members. So how can we help someone who's considering suicide? We can listen, empathize, and offer friendship. We can try to connect, involve the school psychologist or school counselor, or some other type of counselor, refer the person to the suicide prevention lifeline or crisis text line, and seek help, seek help from a trusted adult, a parent, a teacher, someone like that can help. What does the term non-suicidal self-injury mean? Well, some people may engage in what's known as NSSI, non-suicidal self-injury. Such behavior, though painful, is not fatal. Those who engage in NSSI may cut or burn their skin, hit themselves, insert objects under their nails or skin, or self-administer tattoos. Does this usually lead to suicide? Not usually. So who is most risk at this non-suicidal, at risk for this non-suicidal self-injury? So self-injury rates peak higher for females than males. And you can see the different age groups where it peaks the highest. So between about ages 15 and 19 for females and about 20 to 24 for males. So what does research show us about people who engage in NSSI? So people who engage in NSSI tend to experience bullying, harassment, and other life stress. They're generally less able to tolerate and regulate emotional distress. They're often extremely self-critical and struggle to communicate, solve problems, and often they have some problems academically. So what 3 issues have engaged developmental psychologists looking at all this? So nature and nurture. How does our genetic inheritance interact? This is, I don't know how this, I don't actually think that this is the right slide that's supposed to be in here. So I'm going to skip through this one. This is one that belongs in the developmental modules, but important stuff to know about the issues that developmental psychologists want to know. But I'm not sure how this one got into this slide deck. Sorry about that. So to review our learning targets for Module 67, a person with major depressive disorder experiences at least 5 symptoms of depression for 2 or more weeks. A person with persistent depressive disorder experiences a mildly depressed mood more often than not for at least 2 years, as well as at least 2 symptoms of depression. A person with the less common condition of bipolar disorder experiences not only depression, but also mania, episodes of hyperactive and wildly optimistic impulsive behavior. The biological perspective on depression focuses on genetic predispositions and on abnormalities in brain structures and functions. So including those found in neurotransmitter systems. We're talking about serotonin and norepinephrine. The social cognitive perspective views depression as an ongoing cycle of stressful experiences interpreted through negative beliefs, attributions, and memories, and intensified by that overthinking, that rumination, which leads to negative moods and actions and fueling new stressful experiences. So both biology and environment contribute to epigenetic effects, which may play a role in depression. So suicide rates do differ by nation, race, gender, age group, income, religious involvement, marital state, and other factors. Gay, transgender, and gender nonconforming youth lacking social support are at an increased risk, as are people who have been anxious or depressed. Day of the week, season, or social suggestion may play a role. Personal trauma, disconnection, or defeat can also contribute to suicidal urges. Finally, forewarnings of suicide may include verbal hints, giving away possessions, withdrawal, preoccupation with death, and discussing one's own suicide. Non-suicidal self-injury does not usually lead to suicide, but it may escalate to suicidal thoughts and acts if left untreated, so it should be taken seriously. People who engage in NSSI do not tolerate stress well and tend to be self-critical with poor communication and problem-solving skills. Thanks so much for listening. Take care.